Welcome, everyone. Welcome. We begin the session today, and I like to call my friend Isabella Janabas Lacheret for the first topics with Professor Blandine Courbière. They perform the topics together.
Good evening, good afternoon, everybody. This topic about infertility explained to surgeons, what they should know about ART. Initially, we were supposed to do it together, and 3 weeks ago, we weren't supposed to do it together. And for the last 10 minutes, we're doing it again together. So that's why we will be both speaking. The idea of this session is because we need to talk the same language, and we don't talk the same language. The exchange between our two professions in order to properly manage patients with endometriosis is so important. And afterwards, surgeons will tell us what they think we should know. So these are my disclosures. So, as you do know, endometriosis and infertility are no synonyms. And the problem is, when we tell a patient that she has endometriosis, I don't know why, but she hears, I have infertility, which is not true because most patients who have endometriosis will have no problem getting pregnant. So endometriosis is a risk factor of infertility, as much as smoking or being obese is a risk factor of infertility. The prevalence of endometriosis, I don't know how many times you've heard it in the last 48 hours, so I won't come back to it. But since there is currently no cure to endometriosis, the treatment focuses on two goals: reducing endometriosis-associated pain and improving fertility. And we have to try and do both at the same time. The problem is that treatments of endometriosis for all of our patients is medical. And the aim of that treatment is to obtain amenorrhea and ideally never interrupt it. That would be ideal, but we all know that it's not possible because amenorrhea is necessarily contraceptive. And so they do have to interrupt it in order to get pregnant. So if all of the patients have to have medical treatment, only some of them will need either surgery, and that surgery is complementary and compatible with our medical treatment. But some of them will also need infertility management, and that treatment is incompatible with our medical treatment. So in order to start that presentation, I will present the ART specialist nightmare case. She's 30 years old. She's been trying to get pregnant for the last 15 months. She's already previously had 2 laparoscopies for 5-centimeter endometriomas on each ovary, and that was cystectomies. She's never had an MRI. She's had no pill prescribed after her surgery. And she suffers from dysmenorrhea and dyspareunia, so severe that she can hardly have any sexual intercourse. So the fertility specialist who knows a bit about endometriosis will prescribe an MRI. And what do we find at that MRI? That she has DIE with colorectal involvement and small endometriomas. And since we are fertility specialists, we will prescribe AMH and discover that she has low AMH and low AFC. So I hate that surgeon. I hate him because he twice damaged the ovaries. He didn't give a treatment to avoid endometrioma's recurrence. He left DIE to cause the pain. And he didn't warn the patient to quickly get medical advice when she wanted to get pregnant. So improving fertility, which is one of the goals of our management, is a two-step strategy. The very first step is, first of all, not to injure that fertility. And that starts the moment you manage initially the disease. That is, endometriosis diagnosed in a patient not yet infertile, and maybe she'll never be. That means minimal complementary tests, ultrasonography and MRI. And if there are no endometriomas and she's only got endometriosis, you can discuss surgery. It doesn't mean you have to do it, but you can discuss it. And if there are no endometriomas, especially if there are endometriomas, especially if they are bilateral, ovarian reserve has to be quantified. And once that is done, then you discuss surgery and or fertility preservation. Doesn't mean you have to do it, but you have to discuss it. In any case, for these patients, we have to obtain amenorrhea and have an active pregnancy process immediately after discontinuation of the pill. In summary, give a prescription for 3 sexual intercourses per week. That's useful. And then tell them to have medical advice if there's no pregnancy after 6 months. That's the first step. The second step is to anticipate an ovarian failure and or a later infertility. So I will let Blandine take over and talk about blossoms and flowers.
Yes, Isabella asked me to expose my model for explaining folliculogenesis for surgeons, because sometimes we heard that ovarian reserve is the ovarian reserve, and that IMH is the marker of ovarian reserve. It's not exactly that, and I hope I will explain why. So this model for explaining folliculogenesis is very useful daily for patients. For example, when you counsel infertility preservation. So I like to compare an ovary to a cherry tree, okay? And the ovarian, the primordial follicles are the buds. And the stalk is irreversible at the beginning of the spring. So, and the buds don't synthesize any hormones, and you can't see them at sonography. Among this birds population, you will have a growing follicles. The primary follicles are the cherry blossom, and they are growing by wave in green cherries, that is the antral follicles. You can see antral follicles in the sonography because they measure between 5 and 8 millimeter. That is the basal folliculogenesis. After puberty, every month, a cherry among the population of green cherry, among the antral follicle, one cherry will grow and will become the dominant follicle for ovulation. And the cherry pit is the oocyte. And you see the terminal folliculogenesis. With this model, you can explain a lot of things in consultation and in gynecology. And so, IMH blood, the main message of precedent lecture is that IMH blood test is not an exact science. IMH is only expressed by granulosa cells of growing follicles from the primary to the small antral stage, the green cherries, and not the buds, okay? And so IMH levels only reflect the pool of growing follicles that potentially can ovulate and that can be stimulated by gonadotropins for follicle preservation. So IMH is a reflex of a functional ovarian reserve. It doesn't reflect the real ovarian reserve. We use IMH daily in reproductive medicine for predictive the risk of poor response or hyper response, and we use it for defining the starting dose of gonadotropins when we have to stimulate ovulation. But IMH is not a marker of fertility. So it's very important to understand that, because you will interpret differently the article about IMH and endometrioma, IMH and surgery. But it's not another topic. Oh, yes. It's yours.
So, how do you assess ovarian function? So you all know that there are two types of parameters, biological and morphologic. Biological, there's the FSH level at day 3 and the AMH we've just spoken about. And the morphologic are ovarian volume and AFC, okay? So there are also clinical parameters, which is just getting pregnant. But when there's infertility, it's going to be the answer, the responsiveness to IVF hyperstimulation. That means the number of follicles, the number of oocytes, and the embryos abstain. And of course, ultimately, it's going to be the delivery rate. So FSH clearly, if it starts raising, it's too late. We've arrived too late. And it cannot be, and the other inconvenient is that it cannot be measured in a patient who's taking the pill. So this comes to the cherries and all their colors. AMH will be here, and FSH will be when the cherries are rotten. And as Blandine was telling you, AMH is then secreted by the early growing follicles. So I prefer her cherries, so I'll drop my own presentation. So the problem is AMH is the inconvenient of this marker is that it's often the only one we have to evaluate, and especially surgeons, because they are not familiar with ART, and it's easy to prescribe, and because AFC is often difficult. But the fact is it's only predictive of IVF response, and it doesn't give any information on the oocyte quality. And AMH is often low in patients with endometriosis because either they have ovarian lesions, but sometimes they don't have any ovarian lesions and they only have DIE, and sometimes they have nothing but superficial endometriosis and they have low AMH, which makes us very uncomfortable, especially surgeons, because they don't know what they're supposed to do about it. So before, surgeons would never prescribe AMH. Now they prescribe it, which is a good thing. But maybe they shouldn't give an answer about what it means. And don't forget, there are other reasons to have low ovarian reserve. And the other criteria that we have is AFC, which is difficult in endometriosis because what is it worth when you have huge endometriomas that completely squash the rest of the ovary? So what is diminished ovarian reserve? It can refer to several things. It can be poor oocyte quality, it can be poor oocyte quantity, or reproductive potential. And you know that there's the age also that negatively impacts the quality, and surgery that could also impact the quantity. So is surgery risky in these circumstances? There's today insufficient recommendations to say clearly what is a bad ovarian reserve. So just saying to a patient you have a bad ovarian reserve because her AMH is low is something no one should do. Because, of course, if ever she's not wishing to get pregnant, we are thinking of fertility preservation. I won't go into it again because you've had several topics about it and about how many oocytes you need to get a pregnancy. But FP, fertility preservation, is not that non-risky as you presented this morning. There can be complications during treatments. There can be recurrence of pain, worsening of endometriomas, or IVF complications. And we don't know if on the long term, doing several cycles of fertility preservation would not provoke a recurrence of the disease. And those patients could not use their oocytes, as you were explained this morning, or not have enough. So what we believe surgeons should know about ART is that, about infertility, is that please, and that is a message mostly for surgeons who are not specialists of endometriosis, because they are the most harmful, is to think of infertility before it might occur. So every time an endometriosis is diagnosed, think of it. Doesn't mean she's going to have one, but think of it. So, of course, surgeons have to prescribe AMH and antral follicle count, but be extremely critical with the results and not give a counseling that they are not familiar with and address to fertility specialists. Think of FP also, but do not advise it to every patient. and give useful advice about fertility before and after surgery. Too often we see those patients who have been told, I've taken out everything, you can live normally, and you don't have to take the pill, which is terrible. Please systematically include in your, as surgeon, in your copies AFSR and AFI results, in your report, sorry, and inform the patient that she is not cured thanks to surgery, which is regularly what they have heard, and that they must carry on with their hormonal treatment until they wish to get pregnancy. And when they want to get pregnancy, please tell them not to ask too long without a pill when they are trying to get pregnant. And please be nice enough to give these informations to your fellow surgeons during congresses that we don't attend, but you could share with them. Thank you.
Thank you, Isabella and Blandine. Do you have any question for speaker? Nothing? Horace?
Thank you very much for this presentation, for the comparison with the cherry. Now, I think that the AMH should also be explained to all physicians, not only to surgeons, because from while to while we have a patient in which you perform a surgery without endometrioma, without a procedure on the ovary, and then the patient calls us back 6 months later, you killed my ovaries, you killed my ovarian reserve, I am completely infertile because my AMH is 0.8. Because someone told her this. So it is very important to explain to everybody, not only to surgeons. And then the second question is that several authors recently observed that very large endometrioma were associated with high AMH value. The team of Cochin reported this, our team reported this. So it looks like a big endometrioma over 6 centimeters is associated with a high AMH, and once we treat endometrioma, the AMH comes down to probably the normal value the patient would have had if she had not had an endometrioma. So do you have an idea about this relationship which has no apparent explanation?
Okay. For the first question, very thing important to note is that please, after endometrioma surgery, if you have to test AMH, do it at least 12 months after endometrioma surgery. It was my precedent picture, so I do it again. And because after surgery, yes, AMH decrease because probably the surgery have an effect on growing follicles. But if there is a ovarian sparing surgery, if ovarian follicles buds are intact, you will yes. They are growing, and after 6 months, AMH will grow again. So be cautious when you test AMH after endometrioma surgery, not too early, and be cautious when you interpret it. So in my opinion, it's like in oncofertility, after chemotherapy, we don't test AMH before 1 year. It's first thing. I am very critic concerning the 2 publications with, sorry, that show that AMH is increased when the endometrioma size is much larger than 6 or 7 centimeters. Folliculogenesis is a logical mechanism. And the problem is that a lot of people interpret that ovarian reserve is higher in this case. No, ovarian reserve is not higher. Probably, yes, there is 2 hypotheses. Maybe something happened on the growing follicle, maybe an activation, or maybe because it's little studies, maybe it's hazard. and we have to check this data. When it's not logical, I prefer to be cautious. 2, yes, but Cochin studies has 22 patients in every group.
I think we have more than 100. I do not remember, but there is a big population. And of course, the ovarian reserve is not high, but the value of the AMH, which is something which surprised me because everybody speaks about the value. And now I tell to the patient that the value of AMH may go up and down. It does not reflect exactly the ovarian reserve.
We have to come back to the ovarian physiology, I think, maybe with
we observe in so many cases of patients with endometrioma that two situations in fertility, low response or PCO patients, and maybe so the MH higher is lied to PCO patients in association with endometrioma, because so many papers shows the epigenetics reasons for this situation, and maybe as the association. I have so many patients with endometrioma and higher IMH with PCO patients in the ovarian.
Yes, maybe.
Yes. Another question?
I have a question. Do you control the AMH if it's very low? Do you have any time where you control it, 2 months after? Or?
I spend my time controlling AMH because there are, I would have liked to have a biologist explain the different kits of measurements. There are enormous variations of AMH considering the lab, considering the technique. There are automatics or semi-automatics techniques. And I regularly have patients with variations of AMH of 200 or 300%, which makes it something that is absolutely useless, because which one is the good one? I can go from 0.5 to 2.6, and for the same patient in 6 months, and nothing has happened. So really control it, because there are big fluctuations.
And you control the control after if you have 0.5,
It's very
2.6?
uncomfortable. It's very uncomfortable. When you have 3 times AMH 0.2, usually that's the case. And especially you can control it with AFC. I don't know if you agree, but we control it a lot, and we have big variations. But you do it in your lab.
The weight,
Yes, but it doesn't change the strategy.
No, but for you, when you do fertility for managing patients with endometriosis in daily routine, it does.
Yes, but the weight,
but often
weight is important for the MH. In obesity, we found much lower level of AMH. The weight is very important for the interpretation of patients.
But an important message too, that is IMH decrease deeply in users of contraceptive pills.
Yes. Another question?
That is often in endometriosis women.
Hi, I want to know about you about the use of GnRH analog to fertility fertility of the patients after the surgery for endometrioma, 2 or 3 cycles of GnRH analog. If you have a lot of impact, if you agree with the use or not use the GnRH analog.
I use the GnRH analog only in IVF protocol. No, I follow the E3 guidelines about that.
There is a Brazilian. I'm from Brazil. There is a Brazilian theory of silent. When you silence the ovary can great resolution, and it could great fertility outcomes.
Yes. So many papers shows.
Many people have this concept that endometriosis, fibroids, these are estrogen dependent. So after surgery, they feel that maybe if you compare estrogen receptors and progesterone, it is more estrogen dominant. Why not suppress it and then go for your treatments? So that's why it was a routine thing after surgeries to put these patients on GnRH or OC pills.
Progestin.
The thing is that the idea is to give, to exchange on what informations you're not always aware of, and it goes both ways. After discussing the protocols that we're going to use for IVF or not, that's not the topic today. It's not the idea. The idea is really to discuss of those informations that before surgeons didn't prescribe AMH, now they prescribe it, and then everything goes on to that. And the idea is to make you understand that no, don't base all of your dialogue with your patient on that AMH.
Another question? No? Thank you very much. I call Horace Roman. Ah, no. Together. Marcos Allester for the next topics. Thank you.
We respect the parity.
Yeah.
So 2 women, 2 guys.
Perfect.
So as for good afternoon. As for colleagues, we had to do this presentation together, and finally I was the only one, but I have the chance to have Horace with me. This topic is about several points, clue points, for RT specialists concerning surgery for those infertile women before starting an RT. This is the next one. No. Okay. So you all know that deep endometriosis is a debilitating disease for which there remain many unknown mechanisms, and this pathology is sometimes associated to infertility. The mean age at the management of these patients is around 30 years old. And the first question is how to manage the pregnancy intention, and is there a place for surgery for these patients? There are several points explaining the complexity of such management. And one of them is the number of parameters that you have to take into account to make the decision. The couple's priority, the woman, if she feels pain with altered quality of life, what type of endometriosis, what type of surgery you can propose to the patient, and taking into account the surgical morbidity, and of course, the fertility determinant factors such as age, ovarian reserve, and many others. So,
well, but as we are scientists, each time we have a question, we go back to the guidelines to say what the guidelines say. And here we have some guidelines, French guidelines, ESHRE guidelines. And as the guidelines are based on randomized trial, and as we do not have an accomplished randomized trial comparing ART and surgery, the recommendation are not very clear, and I will just ask you to have a look at the recommendation, the guidelines from the ESHRE. We say that there is no evidence to recommend the surgery in deep endometriosis prior to ART in infertile patients in order to improve reproductive outcomes of the ART, except in women who suffer from pain.
So let me share with you our point of view. We think we have to fight against the ready-made management. In one end, you have the surgeon. He will tell the patient, of course, I'm the best surgeon, I have no complications. We will perform surgery, and after surgery, you will no longer have pain, and you will carry out your pregnancy project. And in the other end, you have the RT specialist with good reproductive fertility outcomes, explaining that RT is the most efficient and safe option. I cannot conceive in such complex cases that there can be only one way out. So we think that the aim is to go to the custom management.
Yes, but if you want to be downwards, so let's see the patient, the typical case we have with a patient of 30-year-old on average, who stops the pill and wants to get pregnant, and because she has pain shortly after the arrest of the pill, she has an MRI, and the MRI shows correct endometriosis. So she's not known to be infertile because she has not attempted to get pregnant more than 1 year. But she has a very pertinent question: what should I do? Should I try to get pregnant naturally, even though I have a 4-stage endometriosis? Should I have the surgery, or should I have an ART? And she will ask, which are my chance, my probability to be pregnant if I have ART prior to surgery? And if she asks this question to Ballester, she is on the right place, because Ballester studied this question.
With my colleagues, when I used to work at Tonon Hospital in Paris with my RT colleagues, we published this series 10 years ago, I think. I don't remember, but yes, 10 years ago. This was a prospective cohort of 75 infertile women with in situ colorectal DIA undergoing first-line IVF. And after up to 3 IVF cycles, we found a pregnancy rate of 43% and a cumulative pregnancy rate of almost 70%. So the results were very good. And I don't know if you want to present it. More recently, the team from Cochin Hospital presented this study with a large series of 100 women who also had first-line IVF. And they found up to 4 IVF cycles a cumulative pregnancy rate of 73% and a live birth rate of 65%. So if we take into account these results, there is no debate. The answer is RT. But please, we ask you to think about it, and before taking the decision, to take into account some crucial points concerning surgery. And after that, you'll see that maybe surgery can be a valuable option in some cases, and we are going to explain that.
So if I understand well, if the patient has no surgery and has 1, 2, 3, or 4 cycles of IVF, she may be pregnant in almost 65% of cases, meaning 2/3, which is a good result. And if you go back to guidelines, they say that the surgery may be justified if the patient has pain. But in my opinion, as I'm surgeon of endometriosis, and I speak with patients with deep endometriosis every day, I think the pain is not the major symptom, the major concern in this woman. So I think that ART specialists should not limit their questionnaire to only pain, because there are other symptoms which are more severe and worrying than the simple pain during the periods. For example, let's speak about deep dyspareunia. Deep dyspareunia is a pain, but only if the patient has sexual intercourse. If she has not, she cannot be embarrassed because there is no pain if no penetration. However, the pain, the deep endometriosis, the deep dyspareunia may be the sign of a very big rectovaginal endometriosis that may require, and it may require a surgical solution. Second, another symptom which is not painful at all is the bladder, is the dysuria or bladder dysfunction. So the patient needs to push to void the bladder. It means that the patient may have a deep endometriosis involving the both parametrium, and progressively she will lose the control of her bladder, meaning that she can no longer void the bladder. She had a bladder, a very large bladder with a very weak muscle. So this is a very, very worrying symptom, and I inserted here a urinary dynamic assessment in a patient who had 3 IVF, and the post-voiding residue volume was 300, and nobody asked her how she voids the bladder. She was not very painful under pill. However, this symptom is enough, is sufficient to propose the surgery. So, other patients may have not pain but blotting, a very large abdomen, cyclically or continuously. Yes, because they may have a very severe endometriosis with a huge risk of occlusion, particularly after stimulation for IVF. This is not actually pain, however, it justifies a surgery. Other patients have not actually pain, however, the endometriosis of the parametrium may lead to a stenosis of the ureter and a silent kidney. It means that the patient may lose a kidney, and we remove 4 to 5 kidneys every year in our department in patients who are not particularly pain, however, they...
Sorry, Horace. This is just to say this is a perfect example that you have to ask the question, but you also have to perform quality imaging assessment, because if you don't have imaging, you cannot diagnose this kind of lesions.
You mean that if you perform the IVF, you have to perform first a full assessment of the endometriosis to know who...
This is one of the messages,
yes,
I think.
And last but not least, the patient may have pain, but the pain may not be directly associated by the physician to the endometriosis, because if the patient has pain into the buttock or into the perineum or into the leg, it may be a sciatic or a sciatic nerve or pudendal nerve or sacral plexus endometriosis, most severe. And I completely not advise our colleague to start 1 or 2 or 3 stimulation in this kind of endometriosis, because it may be very, very difficult to manage after. So not only pain, but specific symptoms.
No, the first point was pain, or maybe the good is symptoms. The second point will be relatively short, because you had the presentation this morning. Just to remind you that there are several approaches for these women with colorectal DIA, the segmental resection, the discoid, and the shaving. And you have seen that these techniques, these conservative techniques, are more and more used by surgeons. Another point that seems very important is the cases of the patient who had surgery before you start IVF. And we think that RT specialists should be able to correctly assess the quality of surgery. And one of the key points is how to interpret the surgery. Then you have to see the surgical report. And when you see the surgical report, you can understand if the surgery has been performed by specialists. Of course, the surgery has to give the detailed locations, anatomical locations of DIA, the technique used to remove the lesions, the completeness of surgery, and at least for this infertile woman, the FE score, the IFS score, and the Enzian classification. And after that, you can take a decision. And in some cases, for example, for those patients with a good FE score, you may decide to propose to the patient a natural conception instead of direct IVF. The completeness of surgery is very important. This study was published more than 10 years ago, and it compared 2 groups, 3 groups, but 2 groups are interesting for us. The first one was a group with severe DIA and complete surgical removal, and the second group was same group of patients, but incomplete removal of DIA. And the authors found that for the first group, there were improved fertility outcomes compared with the second, in both natural conception and after IVF treatment, and that the time passing from surgery to obtain pregnancy was shorter in the group with complete removal of endometriosis. And I want to talk about a specific group of patients, as I'm talking about completeness of surgery. Those patients that everybody knows that had repeated surgeries, repeated laparoscopies with adhesiolasis, but without removal of DIA. I think this kind of surgery should be omitted because there is clearly no benefit for the patient in terms of fertility outcomes, with the risk of complications, of course.
Now the patient may ask, okay, so I have 65% of probability of pregnancy if I have no surgery, however, I still have the endometriosis and the symptoms. What happens if I choose the surgery first? So as we have no randomized trial comparing ART to the surgery, we can have a look at series of patients where all the patients had the surgery first. And I come back to my randomized trial, Andor, where the patients with colorectal endometriosis were randomized, we offered the surgery, and they are randomized between two arms, conservative surgery on the rectum and colorectal resection. So the main endpoint was the rectal function, but the secondary outpoint was the pregnancy rate. And 4 years after the surgery, we had a look at what's happened with the patients who tried to get pregnant after the surgery of colorectal endometriosis. And you observed that among the women who tried to get pregnant after the surgery, so surgery first, the pregnancy rate was 81%, and the majority of cases, or majority of patients were pregnant naturally. And as we use the AIF score, we recommended to patients to go either to IRT, either to the natural conception, and among those with natural conception recommendation, 2 had ultimately an ART and were pregnant. But as usual, the question is yes, but they are not all of them were infertile. So if you have a look only to patients who were infertile, we can see that the pregnancy rate is still high, 74%, with a majority of natural conception. So this study, in my opinion, is a proof that the surgery works, because all the patients were stage 4 endometriosis, and we know that the natural conception in patients with stage 4 endometriosis is around 10-15%, but not higher.
Yeah. The goal is not to convince you that surgery is better than RT. We want to explain that pregnancy are possible after this kind of surgery.
Yes.
I think the message is important.
Yes, but sometimes the ART specialists say to the patients, you do not have to have the surgery because then you will be infertile. Ovarian will be destroyed and everything will be finished for you. And this study is the argument that it does not happen in this way.
And one of the reasons is the risk of complications. So with Horace, we published many years ago,
4 years ago.
4 years ago, a series concerning 48 women who experienced severe complications after this surgery. What we call severe complications, according to the Clavien classification, is grade 3 at least, with rectovaginal fistula, anastomotic leakage, damage on the urinary tract. And we had the surprise to see that the pregnancy rate, even after a severe complication, was 42%, and that those women had a pregnancy naturally in 80% of cases. And we were the first to be surprised with the results.
Yes, actually.
So, okay, there's a risk of complication, but as you can see, the impact on fertility is not the one we suspected.
And the overall rate of complication is around 3%, 5%. Yeah. So one woman out of 10, out of 20. No. It's blocked? No.
No. Okay.
Okay, you.
So you said there is no RCT. This is not a RCT. This is a propensity score. A propensity score, we took patients matched on age, ovarian reserve, and the presence of adenomyosis. 2 groups of 55 patients with colorectal DIA. And we compared these 2 groups. The first group who underwent surgery plus IVF, and the second group with first-line IVF. And we compared the fertility outcomes in the 2 groups. And we found that in the surgical group, the pregnancy rate was 60% compared to 38% in the second group. And the cumulative pregnancy rate up to 3 IVF cycles was 80% in the surgical group compared to 56% in the second group. So, okay, it's not a RCT, but you can see that the association of surgery plus IVF allows a relatively high pregnancy rate. Another important message for RT specialists, if you decide the first-line IVF, is to think about surgery in case of IVF failure. These are the two studies that we presented at the beginning of the presentation. The first one, you can see that after 2 IVF cycles, for the third cycle, the benefit is less important. And if you see the second study, only 10% of pregnancies were related to the third IVF cycle. So after 2 IVF failure, please think about surgery, and you have to discuss with the surgeon and the patient, of course, for the place of surgery. I will call it an interval surgery, like we say in oncology. But it's also true in the other way. If you decided the first surgery and the FE score is elevated and you decide a natural conception, you can see that after whatever the FE score, after 18 months, the benefit is less important. So don't wait too much, but you have to think about RT for these patients, and maybe you don't have to wait too much to give them the chances to conceive.
Now, I will just emphasize something. We missed one slide. So on the basis on this data, there are all 2 randomized trials ongoing right now. One in France, other one in Denmark and France. So the first one is the Endofer study, and the principal investigator sit down right here, is Pierre Collinet. Compare the pregnancy rate after IVF versus surgery followed by IVF. And the other randomized trial comes from Aarhus University and in collaboration with our clinic. And it's called EFFORT study. Compare surgery versus IVF, whatever the conception after the surgery. However, the enrollment is quite slow. The number of patients to enroll is very high, so we can provide the results within 5 years, 6 years, Pierre? Yes. So until this moment, we have to do with the data we have, which are, in my opinion, rich.
So to conclude, I think that in infertile women with symptomatic severe deep endometriosis, please do a complete DIA imaging assessment. Ask the right questions to detect symptoms. Ask the advice to an experienced DIA surgeon. Due to the heterogeneity of patients with DIA and the complexity of the disease, we think that we should make a custom-made management. Don't push your luck too far with the IVF in unoperated patients, and in the area of referral centers, we think that these complex cases should be discussed in a multidisciplinary committee. Thank you.
Thank you very much, Marcos and Horace, for your excellent presentation. And do you have any question? Please.
Thank you, Horace. Thank you, Marcos. It seems I heard the same things 10 years ago, and it's very frustrating, I think, because it's exactly what we live in our center, and every day we talk with patients, with RT specialists, and it's always the same questions. And we don't have answers. It means, how can we choose between surgery first or IVF first? So now it looks like we try IVF first, 1 cycle, and if it doesn't work, we propose surgery. What do you think about this?
In what type of endometriosis?
In this type of endometriosis, with rectal involvement or real endometriosis. And I was thinking of, for example, the age. Before 35, maybe surgery is a good choice. After 35, maybe IVF is the best choice. But
I think it depends. You have to ask your question, is my patient likely to be pregnant naturally after my surgery? So does she have bilateral ovarian endometrioma, and is there a risk that I decrease the ovarian reserve, not only the AMH, but actually the ovarian reserve, with the surgery of endometriomas? Is the risk of complication huge? If the risk of rectal vaginal fistula is significant and 40-year, in a patient 40-year-old, that I know that to manage the rectal vaginal fistula we need more or less 10 months, I will propose her to go in IVF. That's why I think it's very difficult to answer like this. You have to see the patient in front of you and to put in balance all this.
Yeah, you say you're waiting the answer for 10 years, and you expect us to give you the answer today. So sometimes you explain the surgery to the patient, and she says, "I don't want this surgery."
Yeah.
So you have
finally, maybe the pain of the patient is the most important element.
Yeah, the pain and the over symptoms. That's why I told you that the randomized trial goes slowly. Why? Because the patient who comes to have an advice, usually when she comes to see me or Michael, she wants the surgery because she's painful, because she did not have the results in IVF. That's why it is difficult to propose the randomization. So there are many patients who ask you, I want this, because I'm too painful. So they have an answer prepared. But I think you have to put in balance all these arguments in order to... And yesterday, Edgardo Somigliana told something very, very interesting. He said, when the AMH is low, don't expect good results from the IVF. Think about the surgery in order to help natural conception. And I think he's completely right.
Exactly. Yes?
Maybe I can just verbalize a patient example, the one I just saw about a week ago. This patient is 31-year-old. She has bilateral endometriomas 5 centimeters each. She has a deep endometriotic nodule about 4 centimeters in size, and she has mild symptoms. She came to see me, we talked about surgery and all the options, and then she went to see a fertility specialist. And when she knew that her AMH may fall, on that basis alone, she decided that she will stay with the conservative surgery than going for an operative surgery. Symptom mild and AMH was her factor which she used, and it picked up the point. So what will you say to this patient first?
We didn't talk about the treatment of endometriomas because we thought that we had to point DIA. My point of view, first, if you decide surgery for this patient, I think that you have to think about conservative surgery for endometriomas and ablation more than excision of the cyst to avoid a damage, an ovarian damage. So I've now 31 years old with bilateral endometriomas and a colorectal DIA, symptomatic with AMH.
25 in picomol, it means 3. It's good.
It's a good AMH.
Yeah. Then you have also, you can separate the treatment of endometrioma from those. You can be complete on the rectum and just drainage or do the ablation of endometrioma. It happens from while to while that we simply drain the endometrioma. Yes, we treat the deep nodule.
With an ablation concerning the endometrioma. And
ablation or simply drainage?
Or drainage.
Simple drainage.
I perform ablation with drainage.
But after this is IVF. So drainage is not followed by natural conception, of course.
Another question?
One question, please.
You show us that surgery is beneficial for result of IRT. Can we conclude, in your opinion, that it will be mandatory before going to IVF to do surgery?
No, but this is not an RCT.
Yeah.
We cannot conclude that. These are the
result.
results of a retrospective study. A propensity score is not a RCT. We matched the patient according to determinant fertility factors, the age, the ovarian reserve, and endometriosis, but it is not a RCT. So we cannot conclude that surgery allows a better result of IRT. We can only see that in this study, those patients who had IRT after surgery had good fertility outcomes. Cannot compare the two.
The study of Pierre Collinet may conclude, if he observed at the end a higher rate of pregnancy by IVF after the surgery, he may conclude our study recommended the surgery be done before. But in this case, we have to look at the patients enrolled in the trial to see if they are representative for all the patients, particularly for the patients who sits in front of you and ask your advice.
I have a question. What do you think about idiopathic infertility with endometriosis, not pains, not signs, after 6 attempts of insemination or 3 IVF? This is a problem of diagnosis. What is the place of the laparoscopy in these cases?
She has a deep endometriosis?
The endometriosis asymptomatic.
No, endometriosis, but deep endometriosis.
No, asymptomatic. We have superficial endometriosis. After we observe so many cases in IVF with the diagnosis idiopathic,
if I remember,
but it's not idiopathic, it's endometriosis.
If I remember, there is a randomized trial for this question showing
Canadian.
that treating superficial endometriosis improves fertility outcomes.
Wait, at what moment you decide of the laparoscopy?
Yes.
After 6 inseminations, 3 IVF?
The problem is that we don't see this patient. I don't see this patient.
This is a big problem in IVF.
The RT specialists see these patients. This is the
yes.
But we have to go back 24 years ago to the study of Marcoux, a Canadian series of more than 500 patients, where the patients had the laparoscopy, and if they had endometriosis, mild endometriosis, they are randomized between excision or just taking a photo. And then, double-blind study, with perfect study from an epidemiological point of view, there was a superiority in the arm of surgery. Unfortunately, an Italian study with the same design did not find the same results. But the meta-analysis pulling together the two studies show an advantage for the surgery. So I think it is justified to propose a surgery, laparoscopy. Particularly in mild endometriosis, where is no high rate of complications.
The problem is the mild endometriosis.
It's one of the only grade A recommendations
we can do.
Because the problem is after you arrive too late. You observe so many cases that patients arrive too late for surgery. Did you comment? Can you comment when endometriosis patients arrive with a late endometriosis surgery?
A light endometriosis?
Late, you said, is this... Yes, late.
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 The disease is too advanced.
Yes.
Yeah, unfortunately, from while to while, not earlier than 3 weeks ago, we see the patients who had 1, 2, 3, or 4 IVF, and with very, very large endometriosis, where we feel that if we perform the surgery, we may have functional unfavorable outcomes. And in one of them, 2, 3 weeks ago, I said, I think the moment of the surgery is back. So continue appeal, and that's why we do not, what Marco said, do not push too far your luck with these patients by adding a new stimulation, because then it becomes unfeasible.
Another question?
Yeah. When we prepared this session, the idea was that there would be as many fertility doctors as surgeons. Could I ask you, who's a surgeon? Could you? Okay, so we didn't quite get what we expected. And fertility specialists? Okay, so is there really an exchange? I'm not so sure. You see the topic of surgery, who's asking questions? It's surgeons. It's not the fertility who are asking questions. And then after the fertility presentation, there was one question of surgeon. And the idea is to dialogue, and this dialogue has to be done and done and done. They were explaining those symptoms that fertility doctors do not look for. And that's the message we have to give them. We're trying to. And they were back to a lot of surgery and always coming back to the same discussions. The idea is really to transmit those informations. She has endometriosis, check the whole endometriosis, and then check all of the symptoms, because that's going to allow us to advise the patient towards surgery or to IVF. And that was the idea of this session.
But you may require one question from each colleague,
yeah,
which is
exactly. Yes, Salma. No, so because I was expecting questions from the fertility doctors to the surgeons, but Salma, you're not a good example because you're both. No.
Maybe they are convinced that RT is the only option.
So we know that for women it's difficult to choose a better strategy between first-line surgery and IVF. Eternal debate. But two things. Which surgeon do pre-surgery consult of the couple? For example, a spermogram. Because if the spermogram parameters are very bad, you will maybe do an IVF in first line. So,
yes, of course. But this is a message.
Of course, I'm not sure.
But this is a message from RT specialists to surgeons.
Yes, of course. Yes, it's important to receive the couple and to do the test for both.
But if the randomized trials show that the pregnancy rate after IVF is better when you do the surgery first, it means that it's also concerned the abnormal sperm parameters.
Yes.
I was surprised by your question because it's the ART specialist who said low AMH, beware, beware. That's it. So maybe she doesn't know about the cherries.
Maybe for answering to my colleagues, for choosing the good strategy, I don't know what is a good strategy, but surgeons have to consider that live birth rate in IVF after 35 years are bad. Reproductive medicine doctors are not magicians. We can do something when oocytes are young, before 35 years, but after 35 years, I think that we have to do all what is possible to have a spontaneous pregnancy, because we are not very bad in with assisted reproductive technologies. Yeah.
Thank you, Dr. Bowser, Dr. Roman, for a great presentation. I think it seems to me that we have to sort of separate ovarian endometriosis from deep infiltrating endometriosis. And the question is that if you have somebody with deep infiltrating endometriosis, they have pain, that it's reasonable to take them for surgery, and it's reasonable to say that their fertility, if they are already infertile, that fertility may actually improve after that surgery if you're not touching the ovaries. Is that a reasonable thing to say?
But she has endometriomas, and you don't touch the endometriomas?
No, she does not have endometriosis. She has deep infiltrating endometriosis, because then these studies actually give us some idea that indeed maybe fertility does improve after that surgery, if she's infertile already.
What you are saying is that you perform the surgery to explain that even if you perform surgery, there is no damage for ovarian reserve.
Correct.
Because you don't touch the ovaries.
Correct.
Of course.
Yes.
This is what Horace told
Because the argument of infertility doctors is indeed that if you take those patients to surgery, that they won't be able to get pregnant afterwards.
Yes,
but it's actually because they don't make the difference between the two.
We have already heard this. Yeah,
right.
There's no support.
Okay, thank you.
Thank you very much, Marcos and Horace, and all the speakers, and see you later.